So small change in the program from what was on your original invitation. And we had Dr. Jens Reuter was originally scheduled to speak today, but Dr. Reuter, of course, is a practicing oncologist and was not able to attend today. But standing in his shoes and with an executive perspective of what's happened at JAX and Lab, of course, we have our own Chuck Hewett. So let me tell you a little bit about Chuck's background for those who might not know that. Chuck joined the Jackson Laboratory in 2004, and he's overseen a number of critical strategic initiatives for the lab, including our research products, the services, the human tumors on mice, lab mice, modernizing the mouse production facilities, including an expansion into California approximately 10 years ago, and of course the current construction that's underway in Ellsworth, which will be the most sophisticated and modern mouse factory in the world, and that'll be in Ellsworth, Maine. He has several-fold over increased the revenue of the lab during the period of time that he's been at the helm as our COO and Senior Vice President. He was really the architect of the development of the Jackson Laboratory for Genomic Medicine, which is our campus that opened approximately 5 years ago outside of Hartford, Connecticut in Farmington, and was instrumental in helping the state of Connecticut be persuaded to provide the Jackson Laboratory with $291 of startup capital and 17 acres of land, which is how we ended up in Connecticut. Money does talk, and Connecticut put some very important dollars on the table for us. Dr. Hewett has been on the Bangor Savings Bank board since 1999 and served as a founding board member of the New York Genome Center and was the founding chair of the Ellsworth Business Development Corporation. Formerly, before JAX, yes, Chuck, despite all those achievements, had a career before he joined the Jackson Laboratory. He was the CEO of Atlantic Energy Partners and Neptune Regional Transmission System, companies that successfully developed an underwater DC transmission system that supplies 25% of Long Island, New York's electrical power. Also served as the Vice President and Secretary to the Board of the Ciambro Companies, an East Coast heavy infrastructure construction company. Previously, he was also the Chief Operating Officer and Chief of Staff for then Governor Angus King here in Maine. He's a graduate from Williams College, and he holds master's degrees and a PhD from Yale. So without any further ado, let me invite Chuck to the microphone.
Thank you, Gregory, and thanks to all of you for coming today to hear a little bit about our story. 3 or 4 weeks ago, Gregory called and said, Jens has a problem. Could you come to the Cumberland Club on April 26th and give a little talk? And I said, well, you know, I'd be interested in that. What would you like me to talk about? And he said, well, I'd really like you to give the audience the story of the history of JAX and tell them about who we are today. I'd like you to explain cancer and really make sure that they understand what a horrible disease that is. And by the way, you really need to tell them about the Maine Cancer Genome Initiative, which JAX has launched with the support of the Alfond Foundation and Greg Powell. I said, Gregory, that's going to make a wonderful afternoon. I said, why don't we start with lunch? We'll break for tea around 3:30, and maybe we can finish up over drinks. And he said, Chuck, 12 minutes. So I've got to get started. As you've heard, putting pieces together from what Gregory said and David said, JAX has just come a long way. For those of you who think of us as the rat farm down east and, you know, imagine a couple of little sheds with air conditioners in the window, let me explain to you that JAX today is a 2,200 person organization. By the way, we're hoping to add 300 this year and get to about 2,500. We have campuses in Bar Harbor, in Ellsworth, in Augusta, in Farmington, Connecticut, Sacramento, California. We have an affiliated lab in Seoul, Korea, and we're working very hard to think about how we will establish a mouse production facility and perhaps separately some sort of research enterprise in China. So we have become, since the days of 150 people that David talked about, or the days really of 8 people in the early 30s when we were all getting started, quite a significant Maine-based nonprofit organization. Our research covers a wide area, and there have been a lot of interesting breakthroughs made at JAX. George Snell was the first person to really understand how the body detects self and non-self. His breakthrough work, for which he won the Nobel Prize, made organ transplants possible. Tibby Russell did the first bone marrow transplants at JAX. Leroy Stevens discovered the ability of teratoma cells to become other kinds of cells. That work led to the understanding of stem cells that we have today. Doug Coleman discovered leptin, which is the gene that helps us determine whether we've had enough to eat or not, and is a key to understanding and managing obesity. More recently, we did the preclinical trials that led to the only drug that's FDA approved to treat spinal muscular atrophy. It was a huge breakthrough just in the last 18 months. We've just taken a compound to clinical trials for glaucoma. We're doing that with Columbia University, but it's based on a discovery that was made in our labs. We have wonderful breakthrough work on Alzheimer's, really understanding the genetics of the disease and identifying targets that may ultimately prove to be treatable. Similarly, a lot of work on addiction. And for those of you who think that addiction might be some kind of moral failing, let me assure you that addiction has genetic roots, and you're incredibly lucky if you're able to stop after a drink or two or after an opioid or two. Genetically lucky. Not everyone is built that same way, and we're working to understand those mechanisms to lead to treatment. But cancer has always been a primary focus at JAX. C.C. Little, our founder, came to found JAX with the hypothesis that cancer was in fact not bacterial, not viral, but rather was based on the genome. And his work, with the exception of a couple of cancers, has largely proven that to be true. You'll hear from Francesca and get a real sense of the exciting cancer research that we're doing today. But let me tell you, cancer's tricky. The subtlety or nuance of cancer is that one cell that mutates does it in such a subtle way that your immune system doesn't recognize it as foreign. And it divides, and it divides, and it divides. With your body, with your immune system, thinking that it's perfectly natural and normal. It's insidious. Cancer is often complex. Today we can sequence tumors, and I'll talk more about that in a minute, and really understand the mutations that have taken place in those tumors. Sometimes it's very hard to put together the puzzle. There can be a half a dozen, a dozen, or even more differences in that tumor between your normal tissue, but learning how that tumor is put together and how it's evolving is critical to understanding its treatment. Now, in the last 4, 5, 6 years, a number of organizations, including JAX, have developed panels that let you look at the genetic composition of both solid and liquid tumors, but JAX is primarily focused on solid tumors at this point. Those panels identify changes that are known to be oncologically or cancerous related. We have also developed what has become the nationally leading database. It's called a clinical knowledge database that links mutations with drugs that are known to work effectively against those mutations. And in fact, we have a team of 5 people working every day on the FDA literature, the scientific literature, to make sure that database is continuously up to date. And it's being used as a reference by a number of pharmaceutical companies and diagnostics firms to make recommendations to oncologists. Typically, when you have medical breakthroughs like this, people who are in large cities where there are teaching and research hospitals, like Boston, like New York, San Francisco, Houston, typically they get access 10 to 20 years earlier to that technology than people would here in Maine. And to me, that's just wrong. You know, if you look around the people in this room, I suspect many of you, if you were diagnosed with cancer, would get in the car and go to Boston, whatever. The truth is, nationwide, 85% of all cancer patients are treated in a community setting, not in a large urban setting with teaching and research hospitals. Here in Maine, I suspect that number is even higher. So we wanted to bring that technology to the Maine oncology community and provide access for Maine patients to that technology, get the right diagnosis, and have your oncologist understand how to interpret that and decide what makes sense. And ultimately, it's got to be the oncologist and the patient who decide what makes sense in terms of a treatment regimen. Thanks to Greg, who was very supportive of this and helped us work with his board. Alphon committed $8.5 million to help us mount this effort, and I'm a little bit sad to say JAX will end up putting in probably even more than that to make this happen. But we are working with every oncology practice in the state, 100%. In fact, we put together the first meeting that ever brought together all of the oncology practices in the state. 91% of the individual oncologists have gotten engaged in our project. And we're also working with the Maine Medical Center Research Institute, MMCRI, to help us evaluate our success and kind of help the process evolve as we move downstream. We've created a network. We've gotten oncologists talking to each other about how to treat cancer at the most modern standard. We're providing continuing medical education programs for them. But perhaps one of the most profound things we're doing is organizing genomic tumor boards so that if their patients get a genomic diagnosis, which is complicated, and they are often complicated, they can get together not only with other oncologists from throughout the state, some of whom frankly are much further down this curve than others, but also with oncologists from Johns Hopkins, from MD Anderson, from Dana-Farber, and from Intermountain Health to discuss what the diagnosis says and what the best strategies for treating it are. Now, in some cases, this doesn't lead to doing anything different than what you would do if you didn't have the diagnosis. But in others, we're already finding that we can direct patients through their oncologist to specific drugs that target their actual cancer mutations. Too early in the project to tell if it's going to make a big difference in their outcome, although we very much believe that it will. It's an exciting project. It's not an easy project. Andrei Antov, who's sitting over here, is one of the major drivers, along with Jens, of the project. We've gotten 200 patients enrolled in the program to date. About 160 have either been tested or are in testing, and many of those have actionable diagnoses. So it's very exciting. To me, there really are two goals. One I mentioned, which is we really want every Maine cancer patient. By the way, there are 9,000 new cases a year, not to mention the recurrent cases that occur in Maine. We want every patient to have access to the best cancer care possible. And obviously the goal is that as the oncologists become familiar with it, they're involving patients outside of our program. And the second thing is, if someone were to come to you and say, gosh, you know, I was just diagnosed with cancer, we want the first thing you say after you express your empathy and sympathy and understanding to be, oh, have you had the JAX cancer treatment profile? Those are really the two goals. And I want to close with a very personal story and show you that I do put my money where my mouth is. About 2 years ago, I got a call from my sister who lives in Minneapolis. And she said, geez, you know, I've just been diagnosed with fallopian cancer and it's not good. It had spread to her colon and her uterus and other places. And she was facing some major surgery. And I said, gosh, you know, is your doctor doing any genomic diagnostics on the tumor? And she said, I haven't heard anything about that. So I spent some time with her. I spent some time with her oncologist, who thought, by the way, that this was a germline test to understand if you had sort of inherited BRCA1 or BRCA2, not the kinds of mutations that we're talking about here that come from a lifetime of living under the sun and being exposed to cigarette smoke and air pollution and chemicals and just plain the cell division that goes along with life. But I explained to the oncologist the difference, and they ordered the test. And the good news from that test is twofold. First, that cisplatin, which is the standard of care, was the right treatment for her. So she was in the 35% of people who benefit from standard of care therapy. And that was a huge confidence booster for both her and her oncologist, and also for me, by the way. But secondly, we've got about a dozen mutations that we can look at again if that cancer comes back and compare with the most up-to-date treatment profiles to see if we can knock it into remission a second time. So, you know, I'm very passionate about this. I'm very passionate about JAX. I'm incredibly appreciative of Greg's support and the hard work that Andre and Jens and others are doing to make this all possible. And I really appreciate your taking the time to let us share the story a little bit with you. So thank you very much. I will close by saying if anybody would like to come to Bar Harbor and see the lab, get to know a little bit more about it, we're always open for that. And let Gregory or me or Katie know, and we'll certainly accommodate a visit.